I am going to talk to you a little bit today about how we use CFAM on our intensive care unit at Birmingham Children's Hospital. It will be a little bit more of a practical guide, hopefully, to how we use that, and then Rishi is going to follow this up with a great talk that supports all the evidence for its use, hopefully. So these are some of the things that we're going to go through. I appreciate some of you may have heard me ramble on about these wiggly lines many times before, so I apologise for that. But hopefully by the end of this session I'll be able to give you a little bit of information that's going to send you away with some basic idea on your approach to take to interpreting what you're seeing on these monitors. With the caveat that some of you will use very different bits of machinery, and so some of the pictures and the examples that I'm going to show you might look a little bit different, but the principles hopefully are all going to be the same. So normally this session is a little bit more interactive, whereby I get you all to say what you see on the slides. In the interest of time today, we may have to whiz through a few of the slides, so just pop in the chat and Harry or Barney will be able to keep up with that and say what you see, and we can have a little bit of chat at the end about that. So I'm not going to go too much on about this because Rishi's going to pick this up, but this is really why we use CFAM in PIC. We know that children have seizures in intensive care. We know that they're associated with adverse short and longer term outcomes, and around 10 to 40% of our population are going to have seizures. The difficulty is that we muscle relax most of our patients, and therefore we can't see any of the clinical correlate that goes alongside children normally having seizures, and so detecting them electrographically using CFAM is important. So we've had CFAM since about 2009. We've had around 11 years or so then of learning how to get this right, and it's still not perfect, and we're still doing that every day. And I think that's one of the most important points that we'll pick up, is that it just needs to be a continuing cycle of learning and education, because this is all about pattern recognition and learning from continuously looking at what you're seeing. We put around 100 patients on each year for around 20-24 hours of monitoring on average, but most of our patients are on for at least a couple of days. And the main reason we put them on is for the detection and confirmation of seizures, and some of this data was taken from a study that we ran in 2014 over a 14-month period. And that's the real use of CFAM, is that it gives us a real-time recording of seizure activity that hopefully we can treat as we see them. Our other proportion, around 25%, go on for prognostication after cardiac arrest, and then we have a smaller group of patients, the more complicated epileptic patients, that go on for ongoing surveillance of their seizures. So although the service at the Children's Hospital is a 24-hour service, which is the full responsibility of the intensive care unit, we do have a fantastic support network with neurophysiology. So they will support us in giving us this governance, education and continued programme of CFAM that we're able to run. But ultimately it remains our responsibility, and they will support us through that process. So what you're going to find working on our unit is that all of these people are involved. We've got the core CFAM team, which comprises of myself, Barney, Harry, and one of the neurophysiologists that lead on CFAM. And then you've got a mixture of neurologists, the rest of the neurophysiology team, but the mainstay of our 24-hour service is led by our PIC clinicians and our PIC nurses. So we can guarantee that pretty much one nurse, two nurses every shift will be CFAM trained, which means they can apply the CFAM to any patient at any time. They can troubleshoot it, they can take it off, and they can assist with pattern recognition and interpretation. But it's the PIC clinicians, that's our AMPs and our registrars and our consultants, that take the responsibility for the interpretation of what they're seeing and therefore the decision to treat. So who are we putting on? So essentially anybody that's muscle relaxed and you can't see any clinical indications of seizure activity, so you're mechanically ventilated or on ECLS, And I would say the default is that all of our ECLS patients at some point do end up on CFAM, particularly all the ECPR patients. That you're muscle relaxed or sedated, that if you're on a thiopentone infusion for any reason, you must have some CFAM monitoring on. And then any of these patient groups that you can see that are at risk of a neurological injury that puts them at risk of seizures. So in 2013, just the end of that, we looked at our study population over a 14-month period. The link to the article is in the Dropbox. And we found that around 12% of our population are having seizures in intensive care. So we compared how well us, classified as the non-experts, were able to use CFAM to detect seizures accurately in intensive care compared to the neurophysiologists as the gold standard. And what we found is that although we don't miss any seizures, so we correctly identified the 12%, we did have a false positive rate of around 11%. And this really is one of the biggest limitations to CFAM on the unit that we've learned over the years, is that there are lots of backgrounds and there is a big risk of artifact that can raise this false positive rate, which we'll talk about in a short while. Most of our children had their first seizure within 30 minutes. And around 60% had their seizures recognised within the first hour of putting that machine on. And again, that was important for us to look at because this is meant to be a real-time measure of seizure activity. And so we don't want to be putting this machine on and then just ignoring the fact that it's there in the background and retrospectively finding these seizures 6 to 8 hours down the line. 60% of all the seizures in the patients happened in the first 12 hours, and we had no children that had any seizures detected after the first 48 hours of monitoring, whether that's because of the seizure profile itself, the nature of the injury, or the fact that we have treated what we found. But again, useful for resource allocation of our machines. For us, we only have 3 machines on the unit, and so this has been a useful factor going forward if we have new patients in and require a 4th machine as to who we should or shouldn't take off monitoring. And again, around 90% have their monitoring started outside of hours, so overnight or at weekends, and most of the seizures that occur, again, are outside of these normal working hours. And this was really why the CFAM service started in the first place, is because neurophysiology are a small team that work 9 till 4 Monday to Friday, and therefore the amount of patients that we needed monitoring on, it was very difficult to get that service going with that limited neurophysiology team that we had. So on our unit, we use the Excel Tech Monitor. We've used that for the last 4 or 5 years with the Headbox, and it has a NeuroWorks software, and I appreciate that many of you might use something different. And the montage that we use is that we have a left and a right hemisphere of 2 electrodes each. We have our earth and reference, and we use ECG positions, but with cortical electrodes to give us some ability to rule out artifact. And we have lots of guidelines that give us some slightly different montages on how to pop your electrodes on in children, for example, that have bone flaps, because it can be very tricky to interpret what you're seeing if you're going to alter your montage to give you any degree of asymmetry. So we've attached all of the guidelines in the Dropbox, but essentially there are lots and lots of flow charts that are going to assist you with your interpretation, because really that is key, because everyone's going to look so different, is just to have this systematic approach. But for the team working on our unit, you're going to make your decision to apply the CFAM, and then one of the nurses on the unit who has been CFAM trained will be able to apply and set the machine up for you and to get that going. And then it comes down to reviewing, and that's really the key, is that you have to remember these machines, although they do have an alarm system on them, we know that the alarm system is not great. It alarms at every little bit of movement and not just seizures. And so in the wealth of kit that's surrounding the patient, they can get hidden. And so we really need to remember to look at them. And so we have a pathway that I'll show you later that helps you to review the CFAM machines. But as a general rule, what we like you to do is to make sure that you look at it on every ward round collaboratively with your consultants and your nurses, and then one in between. And there's a few caveats that if you're obviously changing medications or treating anything, or that the nurses call you to some kind of change in the pattern, we'd like you to go back and have a look at it. And just make sure that you annotate everything onto the CFAM machine itself, which will show you how to do, because this can be kept and is used as the medical record. And when we go back and review all the CFAMs, it's much easier for us to see your thought process on there. Once it's applied, the bedside nurses will fill in this application checklist, which gets basically filed and popped into a database. And this is one of the governance strategies that we take just to ensure that our quality of recording is good and that we know who's being monitored. And there's lots of signs and things that you're going to see around, but again, these are really as those alerts to let people know that you're on CFAM. They'll probably be hung on the front of the bedside monitor. As I said, this machine often gets hidden right at the back and doesn't have an alarm system on. And we don't want to monitor patients on a machine that we don't look at. So what's it going to give you? So you're going to get two components to our display. We have the amplitude integrated EEG, or the AEG, which is going to give you the amplitude of the waves. We run ours around 0 to 200 microvolts. The scale can be changed on the end of the machines. And the amplitude doesn't really correlate to any age groups. As I said, this is about pattern recognition, which we'll go through. And we also run a spectral array, which is a colour-coded frequency. So we have this little bar, which I'll show you on the next screen, which basically codes colours into frequencies, with the red generally being the faster frequencies and the blues and the black being your lower frequencies. So the overall screen is going to look like this, and hopefully you can see my cursor. You're going to get the right-hand side of the brain at the top. You're going to get the left-hand side of the brain at the bottom. So the amplitude, the spectral array, the amplitude and the spectral array. And this section here, which we classically refer to as the CFAM, we run over a 4-hour time base. So the screen that you're going to see is 4 hours. We also run the raw EEG at the bottom, but the thing to remember is the screen that you see on the raw EEG is only 60 seconds. So when you're in live mode, obviously you're going to see this wiggling along, but to interact with it, you need to go into review mode, which I'll show you shortly. And if you can see this thin blue line, that will equate to the bit of the monitor that you're looking at. So wherever your blue line is on your CFAM will give you the corresponding 60 seconds of EEG at the bottom. Down here are annotations, and you're going to find that these are the most useful thing to figuring out those difficult recordings that have got very small fluctuations in there. Nurses, physios, yourselves, anyone that's using this machine can pop as many annotations on there as you want. And this is also where you're going to see what people have previously written on there as a medical record, whether you think this is a seizure or not. So the important thing is making sure that your time base is correct. We set this to 4 hours, but if this is defaulted or someone has changed this to 2 hours, this whole screen is going to look very different. So you're going to see changes that you're not used to seeing. And because this is all about pattern recognition, we need to keep this the same. And we also have different mode sets. So we'll have a neurophysiology mode set where we can run the full 16 channels of electrodes. And again, that's going to look very different. So just always make sure that your time base is the same. And down the side, you're going to get these buttons. Again, in live mode, that's obvious. When you want to review, you need to press this button. And it's okay if you forget to toggle back to live mode, because it will default back within a couple of minutes. And this button here is your impedance check. And this is a really useful button when we talk about in second ruling out artifact. So this is going to tell you how well your electrodes are attached. If you press the button and they all come up green, that's perfect. You have ruled out as much artifact from your electrode contact as possible. If any of them are red, you need to find one of your CFAM nurses to fix those electrodes and sort the impedance out so they're below 5 kiloohms before you decide to go on and interpret the recording. So interpretation. Okay, so hopefully this should be a normal looking CFAM for most of us. And all we want you to do is go through a systematic process, and this is the approach we take at Birmingham, to deciding whether or not you think this is a seizure or not. And if you think it's a seizure, are you going to treat it? And we go through looking at the AEG first, then look at your spectral array, then see if you can get any adjunctive evidence from the raw EEG itself. And we say adjunctive evidence because we're not neurophysiologists, and so we shouldn't be using the EEG as our only source of deciding whether something's a seizure or not. And then make sure that you can definitely rule out any artifacts, and make sure that none of the changes that you're seeing are due to artifact before you decide to treat what you're seeing. And so what you want to do is just imagine you can draw a line underneath the base of the amplitude integrated EEG, and you'd want it to be roughly stable like it is here. Now remember, seizures are generally going to increase in amplitude and increase in frequency, and so if we were to see a seizure, we would expect to see the whole baseline and the top level amplitude increase, so you start to see these notches in the AEG. What we also might see, if we were looking at the density spectral array, are some increase in frequencies with that corresponding increase in amplitude. And so you'd get some of the thicker red colours coming through here. And that colour-coded bar you can see on your main screen will remain above the density spectral array every time. The raw EEG itself, for seizure activity, as a general rule, you're going to see rhythmical, symmetrical spike and wave patterns that are going to run the entire 60 seconds of this EEG. And that's important to note, this is only 60 seconds. So if you're just seeing the odd one or two formed waves, it's probably unlikely that that's a seizure, although it may be an evolving seizure. And that is always the difficulty with these. Depending on how big the changes are and depending on how long the seizures are going on for, it may or may not influence your decision to treat. When you're in review mode, you've got this blue line up. This is the corresponding 60 seconds that you're looking at. You can either use your arrows or you can scroll with your finger. It's an interactive screen. And it will move the raw EEG along. And as you do that, it will move the blue line so that you can see and scroll through. And although it's chopped off the bottom of the machine, down here will be the time. And so as you're scrolling through, you can go from the start of your blue line to the end of your blue line, and it will tell you roughly how long you think that seizure has lasted for. So seizures, hopefully you can all see these. So if we ignore this first section here, but what we were doing is using this approach to go through, and we're drawing this imaginary line underneath, and we've got some stability, and we get to this section here and we've got a definite increase in the amplitude. So that's our first thing we're going to say. There's a change in the amplitude, we think this could be a seizure. Have we got any corresponding changes in the DSA? Yes, we have. We've got these increased red frequencies. And have we got any information from the EEG that's going to help support our decision? We don't have anything that supports the decision here. We don't have any rhythmic or repetitive patterns down here. But the important thing to remember is that currently this blue line, which is the bit of the EEG that you're looking at, is actually not on the bit of the AEG that's concerning you. So this area here that's nice and stable probably doesn't have any seizure activity in it. If we were to move it to this area, we may actually see some evidence of seizure activity here. But remember, the rule is not to focus on the raw EEG. It's there to support us as an adjunct in the ones that are more difficult to determine. And here we've definitely got information that we've got an increased amplitude and an increased frequency. And then we need to rule out artifact. So wherever your blue line is the bit that you're looking at, and what it will do in your annotation section is it will underline or highlight if anybody has done or said or annotated anything at that moment in time. And so this is going to be useful because actually if we were in this section here and we're going, well, we think this is a seizure, but then the nurse has written, well, actually I log rolled the patient and did physio, you might be more cautious about what you're seeing, and you might want to wait and let that procedure finish to see whether the seizure goes away as to whether it's artifact or whether it's a seizure. On the flip side, somebody might have annotated for you that the pupils are dilated, were tachycardic and were desaturating, and then that's giving you some more clinical correlate that goes alongside the fact that you think that this is a seizure. And although this is a more obvious one, lots of our CFAMs look a lot more subtle. They might just look like this first little bit here where you're getting small deflections in the amplitude. And so you're going to really have to rely on your annotations sometimes to help you decide what's happening. So this is that same CFAM from earlier on. And again, we've got it in these smaller sections at the top. So we've got unstable baseline for most of this first section. But this time the blue line is on the area that we're concerned about. So we've got an increase in amplitude. We've got an increase in frequency. And you can see this spike and wave, very rhythmical activity that runs the whole 60 seconds of the EEG. So we've got evidence in amplitude in the spectral array and some supportive evidence from the EEG here that we think that this is a seizure. Hopefully everybody's going to spot this even from the back of the bed space. This is a child in status epilepticus, so we've got no stability to the baseline, we've got constant increases in the amplitude that run the whole 4 hours. And again, you can see the constant increased frequencies with every deflection in amplitude. And I think this is just to state that every CFAM does look different, so every seizure looks completely different. And so the more that you look at these, it is about pattern recognition. They'll become less about wiggly lines and more understanding of what you're seeing. So this is quite a long duration of seizure that starts from the start of the recording up to around here. And again, you've got increased frequencies, increased amplitude bilaterally, and this spike and wave repetitive activity that runs the whole 60 seconds of the EEG. Mm-hmm. It's also really important to remember that seizures evolve, and this is one of those ones that's going to be very difficult to assess because these are very, very tiny. You can barely see them deflections in the EEG here and here, and one that probably I wouldn't expect just looking at the EEG that people would be spotting. What you can see, however, is in that tiny deflection, again, we don't really have any changes in the DSA, but we do have this spike and wave activity coming through in the raw EEG. But as we said, we're not neurophysiologists, and so we're not relying just on that EEG alone. And so if we were to scroll through a time base on here, it probably wouldn't even be a second worth. But if you wait a little bit, in the same CFAM recordings, this has just moved on a little bit, seizures will evolve and they will present themselves, and you can see how they have evolved to get much bigger in the EEG down here. So it's important that we keep looking at these and we use them as a real-time aid. So this looks slightly different because this is on an old platform that we used to use, but the principles are exactly the same. So you've got the amplitude and the DSA, but the opposite way around. And this is in here because although we've said that most seizures get bigger and they get faster, there are some more uncommon seizures that actually get slower and have these drops in the amplitude that you can see here. We've only seen this once in the 11 years that we've been doing it, which is really why I can't bear to throw this slide out. And again, another example of status epilepticus, but again looks very different because you've got a baseline very low level amplitude. So this is probably less than 5, which is why it becomes very difficult to actually see the incremental fluctuations in the amplitude. It tends to just look like single lines, which again can look like a lot of artifact. And so it's really important. Sometimes you do need to change the scale to be able to see what you're seeing in your EEG. And isoelectric occurs quite often. So you're going to get a flat amplitude and no spectral array with a flat EEG, which we have seen quite a few times in our bad traumas. So the other reason for monitoring, which we talked about, is for therapeutic burst suppression. So anyone on thiopentone needs to be on this monitoring because of the risk of flattening out your cortical activity. And you can see this quite nicely on here, where someone's given a bolus of thiopentone and we've lost the overall amplitude of the recording. So to achieve burst suppression with thiopentone, what we want to do is use the minimum amount of thiopentone required to stop your seizure activity. but not suppress overall cortical activity. And so what we say we aim for is this nice, thick, wide band. So it's going to get wider than normal because it's going to drop your baseline activity down. Remember, this is 60 seconds, and so what we want to see is one burst down here of electrical activity every 60 seconds. If you see no burst, then you get a flat line of activity. You need to back off on your thiopentone, regardless of the seizure status of the child at that time. And that patient is probably going to be one where then we need to escalate and start to engage neurology about where we're going with the treatment, whether we're going to stop recording, wake them up, or add in some additional therapies. Again, an old machine. So we have a child here in burst suppression on thiopentone. We've got that very thick, wide band in the middle, but as you can see, we've still got some two significant seizures here. We have a suppression and we have a burst, and we have a very big burst of electrical activity in the raw EEG here. So there's probably room to turn up the thiopentone. And now, again, we've attached the guidelines, but we have some very clear flowcharts and guidelines that tell us how to increment up and down our thiopentone, depending on what you're seeing on your CFAM. So this child did have their thiopentone increased. And as you can see, the overall degree of suppression has significantly gone up. So we no longer have this thick band, we have this greatly suppressed band, which we describe looking like a Nick comb. Because if you imagine that each one of these lines is one epoch of electrical activity that's usually time compressed into 4 hours. As it's become more suppressed, it's become slower, and so you start to see the space between the lines. The concern is that there's no burst of electrical activity down here, and so this patient really would have needed their thiopentone cutting back, despite the fact that actually we can still see there's a very small seizure happening down here. But if the thiopentone isn't weaned or is increased, we can force this into an isoelectric EEG, which we really want to avoid. So it's just important that you follow the seizure pathway and that you think about the use of thiopentone carefully. So sleep-wake cycling is a good prognostic factor. We see this a lot from our CFAMs, but it does cause a little bit of confusion, and it's one of the ones that can be overtreated or diagnosed as a seizure. And so the clue with sleep-wake cycling, and again, this is the benefit of having the raw EEG, is that you get clues from the raw EEG. So instead of having these big, spiky upward deflections in the whole of the amplitude integrated EEG, you get this fluctuating baseline that comes and goes with the sleep-wake cycle. And alongside that, again, instead of having these sharp increases in the higher frequencies in your spectral array, you get the higher frequencies with the sleep spindles that come in and out of the spectral array. And what you will see in your raw EEG is these little sleep spindles that come in and out of your EEG. And that's really your clue that this change in amplitude is not a seizure, but it is related to sleep-wake cycling. You can see those spindles here. And sometimes it actually can be quite aggressive looking, and so I would expect that most people would look at this EEG and say that is not a stable baseline, something is happening here, I think this could be seizure activity. But you're going to go through that process and look at your density spectral array and then look at your EEG, and hopefully by the time you get to the EEG and you see these sleep spindles coming in, it's going to move you away from thinking that this is a seizure and more towards thinking this is sleep-wake cycling. And another one that can get quite confusing, that's often confused for a bit of a burst suppression picture, is to remember that lots of our neonates have a more discontinuous EEG. So you get this thicker wide band on the neonates and a more suppressed overall background, which will increase in continuity as the child gets older, around 40, 42 weeks. And we've thrown these in here because we also see although we primarily use this for seizure activity, we do get lots of other information. So we've seen children that have blown their pupils and had intracranial hemorrhages and herniation. So we've attached this into the Dropbox. This is essentially what we've been through, the process of making sure that there's no artifact, that you've looked at your EEG, your spectral array, and used your EEG as an adjunct to help you diagnose what you're seeing on the machine and decide whether or not you think this is a seizure or not. So the biggest limitation to this is artifact. There's so many sources on our unit of artifact that's going to basically give you the same effect of a seizure. So as you can see on here, we've got a stable baseline all the way along. We do have these random deflections, which are artifact. Again, the difference is you're not giving that big upward sustained deflection in your amplitude. And you've got these small notches here. And unfortunately, lots of our CFAMs do have seizures that look like these small deflections. So the trick is to think about what level frequencies artifact runs at, and it tends to run at the lower level frequencies. And so we have termed this the bar of doom. And as you can see, there's these black tram lines that are appearing in your spectral array, which is generally the level of the artifact that's going to come in. So if you see those black tram lines, the bar of doom, please think artifact and rule that artifact out, figure out where it's coming from before you go in and treat this as a seizure. And this is just really to demonstrate the point. So on this CFAM here, there's a patient having seizures. And if we follow that process, we've got deflections in the AEG. We don't really have any change in the frequencies. We have that rhythmical activity in the EEG. But probably these deflections look a lot smaller and not as convincing as the deflections that you're seeing on the patient that isn't muscle relaxed and has underlying muscle activity. And so without the raw EEG giving us information, you can see that this looks very fuzzy. You're getting these fast muscle activity that's coming on top of the normal EEG waveforms down here. And that's the giveaway that this patient isn't muscle relaxed. But without that, it would be very obvious, or we would like to think this is obvious because we're telling you that upward deflections in amplitude are seizures, to want to treat that. If your electrodes aren't on well enough, remember to use that button to see if they're all green. It's going to give you this very chaotic AEG, which is, again, not a stable baseline. You may want to treat that as a seizure, but it is coming from artifact. And depending on where the electrodes are placed, if they're too close to an artery or it's picking up pulse artifact, you are going to see asymmetry starting to come through in whichever electrode it's near to. And you're going to get this rhythmical activity that comes through in your EEG, but it's not a classic spike and wave activity, and it will come and go. And the trick is to move the position of the electrode. If people don't stop the recording, they leave it running in the background when you take your patient anywhere, CT, MRI scan, actually what you're going to get is the amplitude's going to change. And we need to remember to just stop the recording so that we know it's no longer on the patient. And if you disconnect them, you need to make sure that, again, you stop the recording because it will run live in the background, and otherwise it may look like your patient has suddenly lost all their cortical activity. And to do that, you basically do your impedance check, end and stop the recording, and then just return to the same patient when they come back. Asymmetry is really important. It's a difficult one to decide whether or not your patient's having seizures or whether it's coming from artifact, because it can come from both. So if we look here, the right-sided amplitude looks very different to the left-sided amplitude. And in fact, on the left side, although not so obvious, we are getting these sort of rhythmical changes in the baseline of this amplitude and some very subtle changes in the frequencies on the spectral array. What you can see in the raw EEG is this continuous rhythmical spike and wave activity. And so this is a patient with asymmetry that's having seizures on the left-hand side. However, this asymmetry is down to the electrode positions on a patient that has a bone flap, and therefore the left-sided electrodes need to be positioned further away from the earth and the reference. So we're going to remember that your left and right cortical electrodes are looking at your earth and reference the whole time and judging the amplitude based on that. And so what we don't want to do, excuse me, is assume that one side is more suppressed than the other. And remember to look at the position of the electrodes on your patient whilst trying to rule out, is this asymmetry to do with my electrodes and artifact, or is it to do with seizures? And another clue about your electrodes is making sure they're plugged into the right positions on the head box. So in this patient here, again, we have an unstable baseline. People are going to be calling you to say, we think this is a seizure. But we don't have any ECG here. We have a flat line, but what we do have in the cortical head boxes is what looks like an ECG. So here we have the ECG positioned electrodes plugged into the cortical positions on the head box. And this is why we run our ECG, because it gives us that extra level of artifact reduction and exclusion that we can try and rule out. This happens a lot in our patients, particularly remember that the amplitude of your ECG is much greater than your cortical amplitude. And so particularly in patients that have overall suppressed cortical activity, you can get a lot of artifact coming from the ECG itself. So again, here you can see lots of very small, granted because it's overall low level artifact coming in from your ECG, spikes, spikes and spikes. But you can see that that correlates with every QRS complex that you're getting from your ECG. So it's really important to have a look at that and just to make sure that these changes that you're seeing, these deflections, aren't coming from the ECG, particularly in those that are overall suppressed. And we see the same thing here. We have a massive deflection in the amplitude here that would be a very protracted seizure if it was. We don't have any big sort of incremental spike in the frequency, but again, what we do have coming through the cortical right side is it corresponds with every QRS complex here, so it's coming from the ECG itself. We also, because we use midazolam on our unit, we see lots of superimposed fast activity on our patients, so it lifts the overall amplitude of the AEG itself, but it isn't causing those big deflections. But this is one that just throw up a little bit of confusion. You can see the fast spindling activity that happens in the EEG, and it gives you this kind of double line spectral array of frequencies that the midazolam superimposes onto the top of the normal electrocortical activity. And we also see some very odd patterns that happen in your raw EEG that come from patients having spikes in their ICP. That in the past we have treated as seizures, and we can see why, because the amplitude is definitely deflecting upwards and it isn't that stable baseline that we've talked about. But the important thing to note is that this pattern is not classic of seizure activity in your EEG. And so if in doubt, follow your escalation process, which we're going to show you, and get some more support before you decide to treat. And we see lots of, again, odd artifact that comes from our patients that we run a CFAM on our ECLS patients. And if anyone has any answers about what this artifact is, because we haven't discovered it yet, that would be great to know. So the importance is annotate. Get anyone to annotate everything that they do, because this is really going to help you decide on those more tricky ones where you're just not sure what's happening, whether or not you think this is a seizure or not. So on our unit, we have quite a strict escalation pathway. What we want you to do is look at the CFAM, follow your interpretation pathway, and if you're still unsure, then escalate through to your PICU consultant, who will then seek out if there's any of the CFAM core team available to give some more expert advice. And then the decision will be made as to whether or not we're going to escalate to neurophysiology, because remember that service is the responsibility of us and not neurophysiology, because we don't want to impact on the limited service that they already have. And we are just trialling the ability to do some remote monitoring, so we will see how that goes. The importance is really, as I've said, continued education. You've got to keep looking at these. It's all about pattern recognition. The more that you look at, the better. And so we've got this continued education program that runs for the nurses, the physios, and all of the clinicians, that goes from your initial training right through to annual competence, annual e-learning, and then constant resources of quizzes, case studies, troubleshooting guides. And our CFAM audit meetings, which happen every couple of months, where we'll review every patient that we've popped on in those preceding 2 months as a multidisciplinary team to learn from them. So On the M Drive, you're going to have all of these resources. Every historical quiz and bit of information that we've popped on there is there. So please go and have a look at them and come and find us if you would like some more training. And that's it. Thank you very much.